Well, that's a very flattering warm-up. I'll try to live down to the reality as well as kind of telling you the good news. We got our first MCA motion C5s, must have been just about 3 years ago, I guess. And this talk is not all brand new. I've had to update it a bit. I had to change Anglia ice to Sunquest ice last year. I had a few more references to the National Programme for IT in it than are now probably of interest to an audience, but there are one or two things to say about that in passing. And there's a lot more people obviously behind what you'll see than the guy in front of you. I'm an IT person. Lessons learned about what's successful in this kind of project are, of course, largely about teamwork across a lot of groups and stakeholders in an organisation. In the case of a project like this, obviously the laboratory medicine team, who had some of the really key driving individuals behind years of work that preceded what we've been able to do. And need to say, people on the wards and people, one group I'll mention in particular, the phlebotomy team, the people who collect the blood samples most of the time from our patients on the wards. And people in the trust for various reasons for having an interest in safety and risk issues, who've been backers, clients of what we've been trying to do. Last but not least, our suppliers, Tracline, of course, and Intel and Motion, and also the other players I'll be mentioning in this talk, because this is the kind of 2 or 3 technologies combination, cocktail kind of story. The wireless story and the story about our supplier of an e-requesting system, a system for phlebotomy, formerly Anglia and now Sunquest ICE. So the first of those, 3 years ago, we had an existing system for reporting lab results trust-wide, the most useful electronic system trust-wide that we've got, probably. But we didn't have a requesting system. And along came the fairy godmother of in this case, the London Programme for IT, who decided to provide some interim solutions to their patch, and they offered a couple of best of breeds, which they had quite sensibly decided that could be useful to buy for people. We probably wouldn't have gone out and bought Anglia ice with the business case that we could make internally in the cash we had in our pockets at that time. So we were quite pleased to get this offer from the London Programme, and we're one of about 7 acutes in London who took Anglia through that particular route. There's other people here, I think, who were there before us. So that was the first part. The second part was that 3 years ago we had other aspirations. We'd by that time already put in a while to set about providing printed and barcoded printed wristbands for our inpatients in place of the good old handwritten ones, because of a variety of drivers very well known to many people in the acute sector here, including demands from the National Patient Safety Agency to modify our practice. But the vision behind that came, in fact, to a large extent from people in areas like blood transfusion, haematology, phlebotomy, who were particularly interested in questions of blood safety and positive patient identification and ID safety. In the area of blood transfusion, of course, that's about as important as it is anywhere, any time in healthcare. And they had a big professional interest in finding ways to do things better. The barcoded wristband was part of the solution which they had the vision to initiate. And it was people from haematology who were among the kind of godparents of a lot of work it took on the wards to get that particular change in place. So the vision we had was that the barcode that you see on the wrist on the left could be scanned, and that could be part of a way of providing a fairly complete safety cycle for the blood product cycle, from grouping the patient, identifying their blood type, to administering the blood product, getting it from the fridge, all of those stages through in the use of blood products in trust. And that particular cycle, of course, overlapped with other even wider cycle in terms of events per day, which was collecting test samples, including blood samples, from patients on wards but also in clinics, and getting them labelled and getting those labelled samples delivered to laboratories identified and processed by those laboratories. And I'll walk you through a bit of what we've been able to achieve in parts of that change, not yet all of them, I hasten to say. Okay, so 3 years ago we had a vision about doing these things. We had our wristbands, which we were just about getting sorted. We had an offer of e-requesting. We had a wireless network, which we were also in the process of getting at that time. In the process is the operative word. And the vision was, how can we put all these things together? And bingo, a couple of things came along at the same time. The MCA thing came out, and we read about, indeed, Intel's early case study done at Salford, where they had piloted the use of the MCA. Actually, the first thing they piloted was exactly what we wanted to do. It was doing phlebotomy, generating labels for samples at the bedside and not before, in a way that you could pretty much eliminate most of the chances of mislabeling the sample. So that all sounded very good. We got an ICE offer from the London programme from IT. We wondered, was there any chance that the ICE could adapt itself to using this early device? Wonder of wonders, we rang them up, and Ben Wilson at Anglia told us that they were talking to Intel. Even more wonder of wonders, we talked to the sponsors at the London programme for IT and said, any chance of deviating from the standard package and trying out this new version of the product? And they said yes. So very counterintuitive, not typical of the one-size-fits-all model, which was the death of the National Programme for IT, but nevertheless fantastic. And we had then a deployment which was a kind of small scale of the way that National Programme deployments happen, where you had the local service provider, BT Health, coming along to help and keeping an eye that we did things properly, that we had proper training plans, proper plans for stakeholder engagement, proper plans for benefits realisation, all of those good things. But not too much getting in the way, to be fair, and on the whole being actually rather constructive and useful. Not always the standard story, but it was actually quite a good story. Okay, so far that's what we then have basically done, was to build our patient test requesting system around the MCA wireless and the barcode. And what we've actually done, just to say what we've actually done, is that we've got this operational in all adult inpatient areas at our larger site, the Royal Brompton Hospital in West London, down the Piccadilly line from here. That's not bad. We went live in January 2008, so it's been a while. We covered most of that territory within roughly a year. Most of that's been up since early 2009. That means what we haven't yet done is the whole of outpatients, paediatrics, and the whole of our other site, the Harefield Hospital. And maybe an interesting little kind of sidebar about the problems that we are still addressing to complete that rollout. Now, we actually went along to our neighbours at St Mary's, and we got kind of some fantastic wisdom there from colleagues who've been putting in equivalent functionality with different products at that site. And they warned us that outpatients was tougher than inpatients, largely because it's a consultant-led system. So whereas SHOs can be a little bit more tolerant of being cannon fodder for early adoption of IT, consultants are a bit less forgiving. And indeed the outpatient clinic process is somewhat less forgiving also, as we've discovered. But other issues that have caused us to go a bit more slowly might be of interest are, okay, in the case of the paediatric patient, it took us a long time to find an acceptable way for using the wristband in outpatients. There was quite a strong advice from a lot of our frontline clinical colleagues that young patients find hospitals alarming. Young patients who come along to a clinic find it alarming if they look as if they might be staying there, and putting a wristband on a young outpatient was a sensitive thing to do. It took a little bit of time to find some ways in which we could take the alarming part out of that particular issue, but that was a sensitive issue which took a fair bit of time. The other technical issue relating to pediatrics is still a challenge for us, and that is that you take smaller samples from a child than you do from an adult, and the container which is typically used is also smaller. And that means that the external surface of the container is also smaller. And if you're aiming to print a legible label that contains all the required information and stick it on the sample in such a way it can be then processed by a barcode scanner at the laboratory, it turned out that you had a problem. Now we then invested best part of a year, probably elapsed time, in working with a container supplier to find a kind of thing like a thermos flask, which was 2 layers, a small internal vessel to hold the sample, and a larger external container on which you could put the label. Then we got them, they arrived, and they turned out to leak. So at the moment, we are having a rethink on that. We're hoping actually to find a way we can print smaller legible labels, and we're working with Sunquest, who are very cooperative, by the way, I've got to say, on these topics. Watch this space. But if anyone in the audience has any views on that, I would be really, really interested. The other thing that held us back a little might be of anecdotal interest. It's not so germane to the MCA mobile working per se, but nevertheless, it's relevant to the use of wristbands for identification. And that is that we unfortunately had a clinical incident, a very rare one, because the process we put in place was designed to minimize the chance of misidentifying patients. Nevertheless, we identified a clinical incident where a sample had been mislabeled, and the evidence indicated being mislabeled by scanning the wrong wristband. Early in the morning on a ward, not many people about, and we don't absolutely know 100% exactly how that happened. But it caused us to take a look at our audit trail, and horror of horrors, embarrassment, we found out that we didn't actually have a totally watertight audit trail for knowing who had printed a particular instance of a wristband in a particular place at a particular time. Once you've discovered that kind of thing, of course, your clinical risk leads tend to be rather unforgiving. And our colleagues at the Harefield site quite fairly told us that they would prefer not to go live with processes based upon patient wristbands until we got a total audit trail in place. We then went to our pad supplier, iSoft, who supplied the system with a surprisingly unfortunate gap in its audit trail. And they kindly agreed to correct the gap in that particular legacy version of their pads. Another year passed, and recently we got that particular item in place. So we're now warming up to complete the rest of our particular rollout, involving further use of all the technology that you've seen here. But that's why I'm standing here late 2010, and we've got quite a way to go yet before we've completed that whole story. And meanwhile, our MCAs are 3 years older, and there are various interesting aspects to that. Just a quick reminder, these are some of the things which are national mandates, so very well known to people in acute trusts. What identifiers you have to have. There's an interesting story about the NHS number, by the way, and that could maybe come back to. White, important about colours, and particular rules and regulations about the allergy treatment. And down below you see the way that we do it. We've got the 1D barcode, which is the patient number, and the 2D, which encapsulates all of the 4 identifiers. That's the one that we scan with the MCAC5. And of course the MCAC5 had that magic feature that it had built into it a barcode scanner, among the other interesting devices which can be used taking photos and other multi-talented things that the device would do. But it had the scanner built into the MCA. Okay, so e-requesting, sorry, this is probably a fairly familiar story, but electronic requesting has a few fairly obvious advantages in itself. One is the requests are legible, more likely to be accurately interpreted. Another, that you can process the electronic requests more efficiently, both at the point of sample collection and later at the point of laboratory reception. The main beneficiaries of this kind of